Now, there is something in my brainstem talking to me, which says, should I be uncomfortable giving these drugs to somebody, sending them home, saying, have a nice life, without a formal, time-based follow-up? In other words, please come back in a week, please come back in 2 weeks. Do you do that?
Well, I think you have to have a follow-up plan. And a follow-up plan could be in 3 days or 4 days. If the redness does not go away, see your primary care physician in 3 or 4 days, or anyways, see your primary care physician in a week. As you would say, patients with pneumonia who come to the emergency department don't come back to the emergency department for follow-up, even though pneumonia is more deadly than a skin infection on the average. And so I think that you need to have a plan, and you need to and you have to educate the patient as well. And you have to tell the patient, this is what I expect going to happen. This is when I want you to see your primary care physician. If you are very concerned, you can have them come back to the emergency department or the wound center. But you need to have a follow-up plan for the patient so that you feel just sure about
Sure.
Yeah, I think education is paramount in these patients because, especially if you have somebody that has these recurrent infections, well, they're used to getting 7, 10, 14 days, whether it's an IV antibiotic or an oral antibiotic, and to explain to them why they're getting 1 dose and they're done. A lot of times they get that dose and they're like, all right, where's my prescription? So there is a big component of patient education, but then also, going to that follow-up. If you're sending them out to their primary care physician, you are responsible, in my mind, for explaining a lot of times to the primary care physician what you're doing. They're not as familiar with these newer agents, especially if they're not ever prescribed them, so explaining to them as well what you've done. So I think that follow-up's a very big deal.
It sounds to me like you've got to get some buy-in and maybe some education to the local primary care community.
Absolutely. Absolutely.
Do you reach out to them? Do you have educational seminars? What do you do?
We do. We've tried to reach out, especially if we identify patients, we always try and, within the documentation that we send to the primary care physician, your patient is following up X days, here's what they received. And a lot of times we'll send information about the drug with them. So I think there's a big component of educating the physicians.
Mm-hmm.
And in this case, it makes so much sense to give 1 dose, that's the entire course. From whatever perspective you're looking at, there's really no disadvantage as compared to giving multiple doses of a similar, more toxic, more side effects type of antibiotic, that it's all about the feasibility. And, the education, usually a very small proportion of it goes to why should you do that? And most of it is how are we going to do that? How are we going to put together the program? And I think that once you answer that, and I don't think it's very difficult. And I think that we should also remember that in our hospital, for example, while we use dalbavancin in the emergency department, we use more of it in our outpatient clinics, particularly in our wound clinic. And I think it's important to remember that at the end of the day, our goal is really not to actually get those patients into the emergency department, but actually stop them before if they don't need to get to the hospital at all. And this is a slightly different protocol, but once you make it feasible, and many wound centers see themselves as seeing patients with wounds that may need to be admitted if there is some exacerbation, but they actually try to prevent that from happening with all the care that they provide. And this is just another component that fits very naturally into their work.
You're describing, however, a much bigger program. In other words, the limited program is I'm in the ED, in my hospital, here's a wound infection, I've got this new drug, let's treat it. You're saying you don't want to see these guys. You want them to be so, or the medical environment to be so attuned to it that maybe in one of these urgent care centers, they'll just do it. Or maybe they'll do it in a wound care center distant from the ED.
Or even a hospital that has one of those admission avoidance programs. People come to the ED, they triage the patients to an urgent care center in the hospital itself.
Okay.
They can get the infusion there, and they don't even find themselves in the ED. And if something happens and they need to be admitted or be sent to the ED at some point of time, that's always possible. But
yeah, I think going back to educating those physicians, because not only are you educating them on follow-up, but a lot of times these primary care physicians can send these patients to your infusion center to receive these drugs. So I think being able to help them identify patients as well that they would have otherwise sent to the emergency room.
Mm-hmm. What comes to mind is a phrase which is politically volatile right now, the unfunded mandate. In my view, in medicine, the unfunded mandate is get them out faster, do this better, but there's no money for it and there's no drugs to accomplish it, but they're telling you to do it anyway. Here, you've got some agents that actually work. That's different.
Yeah. For the very first time, we actually have the ability to take away the only indication for the admission, I would say at least half, and maybe more than half, once you complete the infusion, the minute you completed the infusion, the one indication for admission is gone. And how great could it be? I mean, we talked about the statistics and how many admissions we have. How great would it be if we could invest this money in some other field of medicine and care and not in unnecessary admissions?